Today, my guest is John Hertig, the Vice Chair and Associate Professor of Pharmacy Practice at Butler University College of Pharmacy and Health Sciences. John has authored an article titled "A Continuous Observation Workflow Time Study to Assess Intravenous Push Waste," which was based on a study conducted on the waste of controlled substances. So that's the topic for today: costs of the waste of controlled substances. Welcome, John.
Thank you, Terry. Lovely to be here.
Before we jump into the results of your study, tell us a little bit about you and your journey in the world of pharmacy.
Yeah, I'd be happy to. So I currently am a faculty member at the Butler University College of Pharmacy and Health Sciences here in Indianapolis. But that journey never really meant to be academic in nature. I'm a pharmacist by training, did some additional postgraduate education and training at Ohio State University Medical Center in Columbus, where I was training both clinically as well as administratively to be a health system leader. And that's my continued area of passion: entrepreneurship, leadership, management, and then all things patient safety, which led me to my first major career move, which was at Duke University Hospital in Durham, North Carolina, where I helped the Department of Pharmacy there with their quality initiatives, and really fell in love with patient safety as a result. Both patient safety and quality are areas that I'm particularly passionate about, and have carried through those passions in my career, focusing in patient safety and how do we reduce risk, how do we prevent harm. One of the major areas of harm, unfortunately, in this country does involve controlled substances in sterile products, and so this combination is a particular area of interest. And I have both a research program that focuses in sterile products education and compounding, as well as some other fun activities that involve training, including helping do a startup in software startup where it's a virtual reality training program in sterile compounding safety. So I've been able to really own this particular area and contribute to it in a variety of different ways. But with that knowledge and that multiple years of investigation in the space, I did realize that we have some gaps in research, which took me to the study I believe we're going to be talking about today.
Okay, all right, perfect. So you've already given us a lot of background on what prompted this study. Is there anything else that's prompted this specific topic in terms of studying the costs associated with waste?
Absolutely, there are. I mean, if we look at healthcare in general, we need to be better stewards of our resources. And to be better stewards of our resources in healthcare, we need to understand what are the holistic costs. You know, it's not just as simple as one line item. It's multiple costs that contribute to the delivery of care, and a holistic understanding of those costs will help us then steward those resources more effectively. And also, you know, understanding the patient safety implications, and not just the immediate costs in front of us, but what are the downstream effects of the decisions that we're making in healthcare, and how do those then downstream effects contribute back to either safety or cost. And there was a consensus conference back in, I believe, 2018 that took all these really smart people in sterile products compounding and put them in one room and said, how are we safely delivering intravenous therapy today? What have we learned over the course of many years in doing this? And what does the future look like? You know, let's bring a bunch of those really smart people in one room and develop some consensus statements. And out of that 2018-2019 Consensus Development Conference on the safety of intravenous compounding came a few statements. One of those was, you know, do we have a holistic understanding of all the costs that go into safe care? And like, no one said we do. And so that was a red flag to say, okay, we should probably figure that out. And one of the other consensus statements that came out of that conference, Terry, was that manufacturer prepared and ready to administer products, and products that are in the most available and ready to deliver to a patient state, are safest. And you had contributing members from ISMP and other places around the country and world that all agree that they are the safest because they involve the least manipulation at the point of care. It's just literally plug and play. And that's going to hopefully lead to more safe and effective care delivery. So knowing that ready to administer manufacturer prepared products were consensusly determined to be safest, and knowing that we don't have this really good idea of holistic costs associated with delivering care, I started to put these ideas together and say, okay, where are the gaps in the literature so that we can provide this information to decision makers, our chief pharmacy officers, our directors of pharmacy, our inventory control managers, our nurse leaders. How do we arm them with evidence-based information so that they're making the best choices, not only in product procurement, but also in handling, compounding, and administration?
Sure. Okay. All right. Yes, if we could just get the nurses to stop diluting the free package. That's, that's
Absolutely. Yeah. No,
another.
it's funny you mentioned that. I smile like you do, because we've done previous research where even nurses were using like Kerpujects, as little vials, not even using the actual
Oh, totally.
holder, right? I mean, there's all these like variations and workarounds.
I know. I know. I remember the first time I'm like, huh? How do you do that? Oh, I just go through the back. Like,
It's
oh
just
my
a
gosh,
really,
you
really
just
skinny
defeated
vial, right? Yeah.
you defeated the whole purpose. Yes. Okay. All right. So tell us a little bit about your study and what your findings were.
Absolutely. Thank you very much. Well, I'm speaking on behalf of my research team. I was the principal investigator, but it really does take a village to effectively conduct these types of research studies. But so what we were really seeking to do was what are some of those holistic costs to delivering IV care? And we specifically looked at IV push products, and we specifically looked at three IV push products: morphine, hydromorphone, and fentanyl, because they are high risk. They're opioids, they're subject to diversion, there are lots of compliance risks associated with them, and that's what really made me select those three. And what we're looking at specifically is what's their waste and what are the costs that go into delivering that care. We know in healthcare anecdotally that we waste a lot of stuff, because anytime you aren't delivering something and you have to go to the automated dispensing cabinet and waste it, you're throwing away drug, you're throwing away product. And so we always knew that there was waste occurring in our health systems, but there hadn't been a really good quantification of the amount of waste in our product waste, or pharmaceutical product waste, that we had. There had been some models done in emergency room settings and OR settings, but nothing that's actually been witnessed by a human being. And using that time, motion, observation-based study method is really important. It is a gold standard, and we wanted to employ that for this particular reason. In addition to the product or pharmaceutical waste, we also wanted to get at what was called, or what we deemed, the workforce time waste or workforce waste. Any time that we have to go and, for compliance reasons, waste a controlled substance and have that be witnessed, we are not only having the person wasting it kind of waste their time, but also bring over another individual, typically a nurse, perhaps witnessing another nurse. We're wasting that nurse's time to observe. That's taken away from direct patient care activity. This was all done pre-pandemic. And so imagine now, post or current or wherever we are in the pandemic, where we have an incredibly valuable healthcare workforce that's incredibly strapped for time, and that is being paid a lot, particularly travelers and overtime. Are we really making and using those individuals in the best possible way if we're just having them witness and document and comply with all these different waste regulations? So we wanted to get a handle on, okay, how much product are we throwing away, but how much valuable workforce time are we also, throwing away when we're not optimizing product and practice? Those were the two real main aims out of this work, is to get at the product waste as well as the workforce time waste. We collected a few other secondary objectives, Terri, including how often during the waste process they were distracted or interrupted. I mean, there were some, what was the average time to document waste? And so we kind of got these other secondary or tertiary markers, but the primary objective was quantifying the waste.
Did you capture any data on who actually witnesses the waste?
We did, and we know whose signature is on it. We don't necessarily know
whose eyeballs
the witness went. I mean, we did have direct observation, and so we did employ a time, motion, direct observation workflow study to capture the amount of workforce time. We had old school stopwatches, when they started doing it, when they stopped doing it, and then quantified that into costs using Bureau of Labor Statistic data. So we did see some stuff, but you always miss a few things, and some of it was just shouting across the room, and there's all these different variations in practice which we know and we did witness, and there are some safety concerns. I think we had a 31 in total. We had 669 observations. So we had 669 over just 15 days. Remember, these are 3 drugs, right? Over 15 days across 4 units at 2 different hospitals. What that really equates to is 80 beds. So we watched about 80 beds over 15 days. We had 669 observations. 31 of those, the wastes were documented over 8 hours after administration. 8 hours. And so from a compliance or diversion risk, that's a real red flag. That could have just been I forgot it, but it also could have been, oh, I stuffed something in my lab coat or in my scrubs and I went home with it. I mean, you don't know because of that really long delay in documentation, which certainly needs to get flagged as an opportunity for improvement. But yeah, I'm happy to go into some of the other results in more detail too, Terri.
Yeah. Tell us what'd you find in terms of those costs and time and.
Absolutely. Well, again, and I can speak for, this was a major health system. They had decent volume. Some hospitals do more volume in morphine, hydromorphone, and fentanyl than these hospitals. Some do less, so it is going to be volume contingent. Sure. But over 15 days, with 80 beds being observed, we saw over 200 milligrams of morphine or hydromorphone thrown away. And just shy of 18,000 micrograms of fentanyl thrown away. 18,000 micrograms. So if you think just in volume of drug, that's drug that was discarded, or hopefully not. That's floating around an organization from a diversion standpoint. That's stuff that patients didn't use that end up wherever. And to me, that's a major compliance issue, and it does take a lot of time. I mean, if you translate both in the time, it was 14 hours of nursing time over just 15 days, 14 hours of nursing time taken just to comply with waste. And that was a conservative estimate because we only tracked the time it took the nurse to waste and then the time it took another nurse to go to document or witness that waste. We didn't track the time leaving that automated dispensing cabinet. So it was all documented at the automated dispensing cabinet, but we only captured a one-way trip. We didn't capture a round trip because we didn't want to say, well, maybe that nurse then, because she was already in the room where the automated dispensing cabinet was, maybe she now took that opportunity to do something else related to patient care. So we didn't want to get into the minutia of trying to parse that out. And so we did a conservative one-way approach, but chances are they were pulled away from doing something else and then had to go back to continue doing it. But again, that estimate of 14 hours is one way only. That's a lot of nursing time just 15 days.
Yeah. And even trying to find somebody. Did you even capture, hey, can you,
You got it. And that contributed to distractions. I think we had like 80 plus something distractions because of that need to comply, which is a patient safety, workflow, whatever issue. So a lot of time taken to do it. If you look at the drug waste calculation and you compare that to the workforce time or add the workforce time waste, like I said, 14 hours, used Bureau of Labor Statistics data for the average nursing salary across the country. This was pre-pandemic, so that's going to be way up now. But if we use that, we found that using the yearly extrapolation, just 3 drugs, remember, hydromorphone, morphine, fentanyl, 80 beds only, just those 3, 80 beds, if you can extrapolate it to a year, it's over $35,000 in waste. Wow. $35,000 in waste, just 3 drugs, 80 beds. If you look at a per drug cost, it was about $2.40 a drug that you're throwing away. So basically, every time you crack open that morphine, anytime you crack open that fentanyl, you're throwing away $2.40 per dose. Wow. In a workforce, in a healthcare environment where we're really trying to be good stewards of our resources, clearly our research and the evidence that came out of it support the need for us to do a much better job being good stewards of those resources.
Yeah. Do you have a feel for were they not using doses as small as they could have? Like, did they not have the hydromorphone 0.5? The fentanyl now comes in 50, which, when I was at the bedside, it was only 100. So I don't know where that timing was. Were they just choosing not to get those, or did they not come from the wholesaler and therefore were more expensive to get from a centralized pharmacy area.
Right. Well, as you can imagine, it was a mix of both. And your fentanyl one's a really good example, Terry. In fentanyl, as I suggested, just in our study, we saw, nearly 18,000 micrograms of fentanyl down the drain. They at that time did not have 50s available.
Okay.
Okay. So if you look at what was available was a 52 ml vial, so 100 micrograms in a vial or in a dosage form. And 50% of the time, because we tracked all this, about 49.8% of the time, they only used 50. And so they were throwing away 50 micrograms.
Right, right.
So just that switch, or just the switch to carrying 50 micrograms would have eliminated 50% of the waste of fentanyl. Now you're only down to what, 9,000 micrograms.
Right. Well, and of course they could have been getting that 50 from a 503B type of a thing, but more expensive. So it's like, nope.
Got it. And there's a little bit of a reticence still to use some 503 facilities based on shortage or sterility issues or whatever. But and so it is a mix. I think one of the key takeaways that you're alluding to, Terri, is that we really need to be matching the product with practice as much as we can.
Yeah.
But there are a lot of things working against us. One is maybe the manufacturer doesn't carry it, or maybe we can't get it or from a 503B facility, or we don't have the ability to outsource. Maybe it's on shortage, right?
Yes.
Shortages continue to be a major issue, but you see order sets that are created knowing that you could source that product, but that product is never even sourced they just go for the cheapest thing on the register rather than thinking through, do I want to match product with practice, because I'm going to save holistically a lot more money than the incremental couple cents more that is on the register.
Right. Yeah. What would you say to directors of pharmacy that, okay, they see the research, they see the cost, but their bottom line is the product that they order. They're not going to, see the savings on the nursing time and that's not their department.
Yeah, well, these are conversations I have frequently with our DOPs and chief pharmacy officer colleagues who say just that. And that, I think, it does require a little bit of a change in mentality that, look, it's my department, it's my budget, that's what they're looking at. But I think putting some pressure on our executive level leaders within our health systems who are looking at any way to save some money right now and thinking cross-functionally is a more contemporary way to lead our pharmacy enterprise. Is that, yes, it's our budget, but it impacts everybody. And if I can work with our nursing leaders and communicate effectively, look, it's going to make nurses happy. It's less manipulation. They don't want to be doing that stuff, right? And if I can get a win for them, if I can save the health system holistically some money, maybe that's worth a little bit of a bump in the budget, as long as my C-suite executives and my counterparts understand what it means to the system. What I would encourage people to do in order to engage in that dialogue, Terri, is, use some of the method that we've done in our research. You don't have to reinvent the wheel, copy what we did and get tested on some medications at your own facility. Don't just take my word for it. Use our approach and validate it at your own facility and see how much you could be saving. I mean, doing that is really helpful if you're going to engage in your with your C-suite or your other leaders on going down this road with this project, to say, look, there's evidence out there that's peer reviewed that says this is what happens. We tested the approach in our own facility. Yeah, we're wasting this. If we made XYZ change, we would save a considerable amount of money.
Yeah, well, and just employee satisfaction. I mean, you mentioned nurses don't want to be doing this. I remember very, very clearly at a hospital that I was at, regularly, the ED nurses in particular would be like, Terri, why don't we have hydromorphone in 0.5? Well, it didn't come that way at the time, right? It was just 1 milligram. And it's like, oh, I'm always going to the, machine to waste. When it did finally come out and hey guys, good news, I was literally their best friend. It was like I had manufactured it for them. They were so excited. And you're right, they don't want to be doing it, and to know that every time they pull it out, they're going to have to, find that witness and be disrupted and go, witness the waste, it's a problem. And then did you take any factors into consideration in terms of monitoring for diversion? I mean, the resources that you put into the person who has to reconcile or should be reconciling all of that. And then now we've got some missing waste, or, oh, there's a lot of waste. Is that a practice? Is that justified? Is that diversion? I mean, there's resources there too.
There are, and we didn't capture all those. It wasn't part of the method, but we did mention it in the discussion, because you're right. We didn't talk about the investment in the investigation piece, or the compliance piece, or the chart reviews, or even the waste disposal systems that are designed to render products irretrievable and irrecoverable. You know, those come with a cost too, as we're filling those bags and jars and bottles up. And all those are additional costs. That's why when I say what our data is, it's conservative, because I guarantee it's actually more costly than what we presented as part of our research. We have talking a lot about cost, obviously, as part of this discussion, but you, Terri, so aptly mentioned these other factors that are really important, which are satisfaction. You know, making nurses happy is good. Making pharmacists happy is good. Taking those 14 hours over 15 days and applying that back to direct patient care is good. You know, compliance with regulation is good. Patient safety is good. Like, there's all these really compelling arguments. I start with cost because it's the one that, you know, obviously piques everyone's attention first. But there are all these other intangibles that surround this issue, which make this, you know, matching product with practice, you know, the most ready to administer products, if at all possible, is so important, because it does not only have a really beneficial cost impact, but a holistic healthcare impact.
Yes, yes. And waste is a very easy form of diversion. And so there's that piece of it too, the health of our staff. You know, if we make it easier for them to sample, let me just try it, you know, get away with it once. Okay, now I can get away with it all the time. So there's that piece.
It's huge.
From a health perspective. Yeah.
It's huge, and it's not going away. And I mentioned the numbers rather than the cost of drug, the pure volume of drug, because you're right. It's floating around our organizations, right? If you have just shy of 18,000 micrograms of fentanyl just ready to be diverted, I'm not saying any of it was necessarily, but it does present an opportunity to. And then you look at some of these trends in compliance in terms of charting and documenting waste. What we saw is actually we tracked in trend a 24-hour period of time on when and how quickly everything was charted. And you have, you know, it looks like this, right? Because it's up and down, maybe 15 minutes, 20 minutes, 40 minutes. But then you have this like two big spikes, huge spikes. And those spikes were at shift change.
Sure.
As you can imagine, you know, nurses are really busy. And so rather than chart or document in the moment, they're stuffing their pockets, they're, you know, wherever it is, they're setting it on the automated dispensing cabinet, and if shift change, they're going through and they're reconciling and charting all their stuff. Well, we all know it happens, but from a diversion best practice standpoint, that's concerning.
That's the perfect time.
It is the perfect time. And you know, if you feel like you don't have diversion, it means you haven't looked for it, right? I mean, that's like the common thing in this line of business is everyone knows it exists, but you got to go look for it. And you have to have systems and practices and processes built in that allow you to quickly identify it and rectify it. Well, seeing those two blips to me is something where if I'm a leader in that organization, I'm going to go take a real hard look at what's going on in terms of our waste documentation and charting practice.
Yeah, for sure. And I interviewed a nurse who's recovered from substance abuse that she said at one point she realized, wow, we waste a lot of drug. You know, and that was you know, I mean, maybe she would have found another way or done something different, but it occurred to her that that's just trash. I mean, we're just going to throw it out, and there's a lot. So that's what, you know, she first exposed herself to in terms of the waste.
There is a lot, and a lot of people aren't looking for either, or looking in the wrong places. And I mentioned the OR and procedural areas. That's one of our next steps in terms of research. We quantify these in more general medicine and step down and critical care. We're going to the ORs and procedural areas next, like the proverbial pharmacy black hole, because we know that that's a whole different beast when it comes to documentation and compliance, and the volume is high. right?
Yeah.
I mean, in those areas, the volume is really high. And so I think we're going to see similar outcomes, but potentially on an exponential level.
Yeah. Well, in the OR, sometimes they just use it all up so they don't have to waste.
You know what? It's funny you mentioned that, Terry, because that's going to be one of our outcomes is
Okay.
when you don't match product with practice. If you have a 4 milligram presentation and you only need 3 for a patient, rather than take 3 all the time, just push it. And if we need to intervene, we have the mechanisms to do
We're
that. So we're
ready.
actually
That's
designing a
right.
study that's going to look at what are the after effects. So length of stay, post-operative nausea and vomiting, interventions, both medical as well as supportive. Are those greater when the order called for one thing and you gave a little extra? So
Right.
you're right. You're
Right.
absolutely on to
Right.
where we're going next with it.
Interesting. Okay. Well, that'll be interesting. Have you had any of your affiliate hospitals or any other hospitals that you've heard of that have made changes after reading the results?
They have. Yeah, I've had a number. I mentioned earlier, I work with a few different hospitals and I've had conversations with DOPs and chief pharmacy officers, and they are starting to do this. We are hearing of these changes. Having presentations like the 50 microgram fentanyl is a great example of people saying, look, we were throwing away half of this. We're so glad this exists.
Yeah.
And so, yes, I do see some of those changes. They're up against it, when it comes to product availability. Drug shortages, restricted access is still an issue. And so that's an opportunity for our industry partners to continue to focus on inventory, on making sure that we have consistent production processes, making sure that lines don't go down and that we have flexible lines in terms of manufacturing and upscaling. And so I know our industry partners are on it. I know everyone's trying to do the best they can, but clearly there's an opportunity for us to continue to do better when it comes to drug shortages and availability.
Right. Wonderful. All right. Well, this is great information. I'm looking forward to seeing the results of your next study as well. And thank you for, it takes time. And like you said, it takes a team to do things like this, but I think it's very valuable. I mean, we know as pharmacists there's a lot of waste, and obviously that's costing more, but without really going through and taking the time to do the study, really looking at the numbers and really analyzing, one, we don't know where the difference is, right? In terms of a little bit more upfront, but we're wasting, what is the break even? But then we certainly don't even think about quantifying all of those other things either. So this is great data. Thanks to you and your team for doing that.
Thank you for the opportunity to talk about it. And you're right. When I discuss this with my colleagues, they're like, we knew there was a lot of waste. It's not rocket science, but thank you for actually quantifying some of it and putting a method together that can be replicated, because that would be the greatest, benefit from my standpoint. And that would make me happiest if people take what we've done and go do it at their own facility and start quantifying their own waste and then adopting practices to limit that, because we do need to be better when it comes to stewarding our resources and working cross-functionally. It's not just about pharmacy, right? It's about the entire health system and how are we working together to not only support our colleagues when it comes to diversion, but provide the best, safest, and most effective care.
Yep, you're right. We are all integrated, and we forget that sometimes, but one process affects the next process and makes a big difference. Yeah. Well, thank you very much, John, for your time. Good work, and keep it up.
Oh, thank you, Terri.